Hello everyone, welcome back to my channel Dental Explorer. I am Dr. Prasad. Today I shall be sharing an interesting and challenging implant case involving immediate implant placement in relation to the tooth number 24. This case was unique because the patient had a grossly decayed tooth, a periapical abscess, and a buccal cortical defenestration defect. Despite these challenges, we were able to successfully place an implant immediately after extraction. Let's go through the entire case step by step. Case introduction. This is a 55-year-old male patient who reported with a severely decayed upper left first premolar. The patient was medically compromised with diabetes, hypertension, and was on medication for both conditions. Also taking ecosprin 75 mg as a blood thinner. After evaluating the medical status and obtaining physician clearance, we proceeded with the treatment planning. Preoperative radiograph. On the preoperative IOPA, tooth number 24 showed extensive coronal destruction along with a well-defined periapical radiolucency suggestive of a chronic periapical abscess. Clinically, the tooth was non-restorable, making extraction and implant placement the most suitable treatment option. CBCT analysis. Since this was a challenging case, a CBCT scan was advised. The CBCT revealed buccopalatal bone width of approximately 8.1 mm, available bone height from the crest to the sinus floor of approximately 15.17 mm. However, the most important finding was the presence of buccal fenestration defect associated with the infected tooth. This helped us anticipate the surgical challenges and plan the implant position more accurately. Treatment planning. Our treatment plan included a traumatic extraction of tooth number 24, thorough debridement and curettage of the infected socket, irrigation with saline mixed with tetracycline for disinfection, immediate implant placement, guided bone regeneration using a combination of autogenous bone and allograft, coverage with a collagen membrane, primary tension-free closure. Surgical phase. After administering local anesthesia, an traumatic extraction was performed to preserve the remaining socket walls. A full thickness flap was reflected. All granulation tissue was meticulously removed from the socket. The site was thoroughly irrigated to reduce the bacterial load. Osteotomy preparation was then carried out while maintaining ideal three-dimensional implant positioning. A 4x13 mm implant was placed. Primary stability was achieved with satisfactory insertion torque, making immediate implant placement possible. Following implant placement, the jumping gap as well as the buccal defect were grafted using a mixture of autogenous bone and allograft. A collagen membrane was placed over the graft, followed by tension-free primary closure. Healing phase. The patient was recalled after 4 months. Clinical examination revealed satisfactory soft tissue healing. A remote crestal incision was made to expose the implant. The cover screw was removed and a healing abutment was placed. Prosthetic phase. Another 15 days, healthy peri-implant soft tissue was observed. The healing abutment was removed. An impression coping was placed and an IOPA was taken to verify complete seating. An open tray impression was used to obtain an accurate implant level impression. The impression was then sent to the laboratory for fabrication of the definitive prosthesis. Clinical pearls. This case highlights several important clinical points. First, immediate placement can be considered even in infected extraction sockets, provided proper case selection and meticulous debridement are performed. Second, CBCT evaluation is essential for identifying defects such as fenestration and planning implant positioning. Third, achieving good primary stability and performing guided bone regeneration are the key factors for successful outcomes. Disclaimer. I would like to emphasize that every implant case is unique. Treatment decisions should always be based on proper diagnosis, case selection, and sound surgical principles. This video is intended purely for educational purposes. If you found this case interesting and informative, please like this video, share it with your colleagues, and subscribe to the channel. Let me know your thoughts or questions in the comments below. I am Dr. Prasad Damse and I shall see you in the next clinical case discussion. Thank you for watching.